Dr. Limonte will launch grand rounds this morning, followed by Dr. DeBoer, and then Dr. Wong will wrap up the session from in the 9 to 9:30 slot. So without further ado, Dr. Limonte.
Thanks, Matt. So for those of you who don't know me, my name is Christine Limonte, and I'm a clinical research fellow and acting instructor here at University of Washington. And I will be kicking off a diabetes power hour with a talk on the role of kidney biopsy in diabetic kidney disease. And here's an outline of my talk. First, I'll be reviewing correlations between histopathological features and clinical features in diabetes. Next, I'll talk about how histopathological features may predict long-term outcomes. Then I'll go to how this translates into our decision-making process for performing biopsies in people with diabetes. And lastly, I'll touch on what I view as the possible future for the kidney biopsy in diabetes. To set the stage, I want to review the classic timeline for diabetic kidney disease progression. This timeline was described for type 1 diabetes and has been used as a framework for thinking about type 2 diabetes, even though it's not completely applicable in this scenario. So in this framework, glomerular hyperfiltration is the first indicator of diabetic kidney disease, though this is difficult to identify clinically. And early on during this time, glomerular lesions may be present. Microalbuminuria is the first detectable sign of abnormal kidney function, and after this, eGFR declines. And then progressively over several decades, albuminuria, eGFR, and glomerular and other structural lesions worsen concomitantly and ultimately result in kidney failure. In terms of structural tissue abnormalities, glomerular lesions are the most distinctive of diabetic kidney disease and the best described. And GBM thickening occurs 1.5 to 2.5 years after type 1 diabetes onset. Mesangial expansion is apparent 5 to 7 years later. And then in later stages of disease, characteristic Kimmel-Steele-Wilson nodules develop. Finally, global glomerulosclerosis is our end-stage lesion for the glomerulus, where it is completely scarred over. In 2010, the Renal Pathology Society devised a glomerular classification system for diabetic nephropathy that largely corresponds to these 4 lesions. And the goal here was to develop a consistent method for describing glomerular lesions for clinical and research purposes. These classes were chosen because they roughly correspond to clinical features and prognosis, which I'll go into more detail about soon. Class 1 corresponds to our GBM thickening. Class 2 is split into 2A and 2B and corresponds to mesangial expansion. Class 3 to Kimmel-Steele-Wilson lesions, and Class 4 to advanced diabetic glomerulosclerosis. This report also includes a classification system for interstitial and vascular lesions, including interstitial fibrosis, tubular atrophy, interstitial inflammation, arteriolar hyalinosis, arteriosclerosis, and the presence of large vessels, but I won't go into more detail on that specific aspect here. So unfortunately, the clinical and histopathological timeline I described doesn't hold up entirely, especially in type 2 diabetes, which has proven to be a quite heterogeneous disease process. Ways that diabetes is heterogeneous. Well, clinically, eGFR decline can actually precede albuminuria. Albuminuria remission can occur, and eGFR decline and increase in albuminuria do not always have a linear course. This can occur more precipitously than people tend to expect. Histopathologically, there's also a tremendous variety in glomerular, tubulointerstitial, and vascular lesions. Severity of lesions doesn't always align with the clinical course, and the degree of injury in one compartment, like the glomerulus, doesn't always correspond to that seen in other compartments, like the tubulointerstitium. Also, glomerular lesions, pre-global glomerulosclerosis, may be reversible. And this has been shown in pancreas transplant recipients who've had serial kidney biopsies. And so now I'll go into more detail on how exactly histopathological and clinical features relate to one another. So generally, albuminuria correlates with severity of glomerular lesions across our typical albuminuria categories of normal, micro, and macroalbuminuria. Here is data from a study that was conducted in an autopsy cohort with diabetes that had an N of 106. Subjects were older, around 77 years old, had a mean EGFR of about 60 and an A1C of 6.7. This was from the last visit prior to death. Overall, 60% of subjects had lesions consistent with diabetic nephropathy. And here you could see in the legend, these correspond to the Renal Pathology Society classes I showed you earlier. In the normal albuminuria group, 34%, that's the gray box here, had class 2A lesions, mild mesangial expansion. Perhaps even more surprisingly is that 17% of these folks had Kimmel-Steele-Wilson nodules. Now in the microalbuminuria category, there's more mesangial expansion. And then ultimately in the macroalbuminuria group, we see that half of the subjects have Kimmel-Steele-Wilson nodules. More severe lesions were also seen among those with greater albuminuria, even in the normal, what we consider to be the normal range. 80% of those with a urine albumin creatinine ratio of 15 to 29 milligrams per gram creatinine had glomerular lesions compared to 40% with less albuminuria. And I will acknowledge that our numbers are small here. There was just about 15 people for each of these categories. And this is overall consistent with other reports of glomerular lesions in people with normal albuminuria and EGFR greater than 60. Interestingly, changes in glomerular features over time are associated with changes in albuminuria as well. This is from a study conducted in 48 participants from a Pima Indian cohort with type 2 diabetes, who were randomized to losartan versus placebo. Participants had biopsies performed at baseline and after 9 years, in which glomerular morphometric features were assessed. And what they found was that change in glomerular basement membrane width, mesangial fractional volume, lower surface density of the peripheral glomerular basement membrane, glomerular volume, and percent sclerosed glomeruli all correlated significantly, most positively, this metric negatively, with change in albumin creatinine ratio over time. However, none of these features correlated with change in EGFR over this time frame. Important to note is that participants had minimal albuminuria over the course of this study, but overall it was a doubling in albuminuria from 15 to 30 milligrams per gram creatinine. And they appeared to have high normal EGFRs that is likely consistent with hyperfiltration. Specifically, this metric, mesangial fractional volume, the proportion of glomerulus occupied by mesangium, has consistently had some of the strongest correlations with albuminuria, both here and in other studies. Tubulointerstitial and vascular features also correlate with albuminuria. These lesions are generally less well characterized, and this association is less well described than that between the glomerular features and albuminuria. These figures on the right are from the autopsy study I mentioned earlier, and as you can see, across increasing categories of albuminuria, there's more severe IFTA, interstitial inflammation, and arteriolar hyalinosis. The presence of vascular abnormalities I found to be pretty interesting because these seem to be present in a majority of people with diabetes across a wide range of albuminuria and EGFR. Came across one nephrectomy study that reported that as many as 90% of people had moderate hyalinosis and arteriolar sclerosis. Generally, you also see lower EGFR with more severe glomerular lesions, but this may depend on the biopsy cohort. And also, interstitial fibrosis and tubular atrophy correlate with EGFR as well. The figure on the right shows data from a study of almost 900 adults who had nephrectomies, who had a history of diabetes and hypertension, both or neither. And overall, across the board in these three groups, lower EGFR was seen with more severe lesions, interstitial fibrosis, tubular atrophy, and glomerulosclerosis. Notably, those with hypertension and diabetes, the yellow lines here, consistently had more severe lesions across these compartments for any EGFR than those with hypertension alone, the red line, or without these conditions, the blue line. Overall, it appears as though early in diabetic kidney disease, glomerular lesions correlate better with eGFR, and later in advanced disease, tubulointerstitial lesions correlate better with eGFR. And I want to note that many of the papers I've been citing are authored by our very own Behzad Najafian. And so moving to histopathological correlations with long-term outcomes. These are results from one of the larger type 2 diabetes clinical biopsy cohorts I came across that includes almost 400 people, the primary biopsy diagnosis of diabetic nephropathy. Participants were around 50, had an eGFR in the 70s, and 1.5 grams of proteinuria a day. They were followed for about 29 months. Overall, more severe glomerular lesions, and this is corresponding to the classification system I showed you earlier. IFTA, interstitial inflammation, arteriolar hyalinosis, and arteriosclerosis had worse renal survival. That's eGFR less than 15 or dialysis initiation. But only increasing severity of glomerular lesions in IFTA were associated with renal survival when accounting for some baseline factors like proteinuria, eGFR, and blood pressure. Other lesions that we talk about in diabetes, like microaneurysms, hyaline caps, are also associated with kidney outcomes. But in the study, were not associated just when considering glomerular lesions as a whole. Similar associations with long-term kidney outcomes are seen across the spectrum of kidney disease as a whole, not just in diabetic nephropathy. And the Boston kidney biopsy cohort, which included clinical biopsies with a variety of primary diagnoses listed here, including GMs, global glomerulosclerosis, IFTA, and arterial lesions, were all associated with kidney disease progression, which was here defined as eGFR decline greater than 40 or need for dialysis or transplant. And these associations were significant, even accounting for things like baseline eGFR, proteinuria, age, and diagnosis. In addition to degree of glomerular pathology as a whole, individual morphometric features are also associated with kidney outcomes. In our Pima Indian cohort with type 2 diabetes, a number of morphometric variables were associated with eGFR loss over 6 years. Features in red were associated with worse outcomes, and those in green were associated with better outcomes. And models studying these were accounted for age, sex, diabetes, duration, or typical confounders. Interestingly, a glomerular index combining all of these features was better at predicting long-term outcomes than most of the individual measures. And the reason I thought this was interesting was as an example of how going beyond our more traditional classification system for diabetic glomerular lesions may be pretty informative. So putting all this together, there's clearly evidence that histopathology can tell us something about how diabetes is affecting the kidney that is distinct from albuminuria and eGFR. So why don't we biopsy people with diabetes more often? I want to frame the discussion of when we choose to perform a kidney biopsy with findings from this recent qualitative study in which nephrologists were asked about their attitudes towards need of kidney biopsy. The factors that contributed to the decision to biopsy fell under 4 main themes: ease of arranging biopsy, prior exposure to biopsy during training, concerns about biopsy risks and patient preferences, and the perceived usefulness of biopsy in helping with diagnosis, prognosis, or guiding treatment. When asked specifically about biopsying patients with diabetes, some nephrologists expressed that biopsy often added little to the clinical diagnosis of diabetic kidney disease. Representative statements included, "I used to biopsy patients with diabetes but no retinopathy, expecting to find something other than diabetes, and every last one of them had diabetic nephropathy." And "I biopsy when it does not follow the expected natural course of the disease. If someone has microalbuminuria, proteinuria, progressive proteinuria with a gradual decline in kidney function over years, I would not biopsy." In contrast, Some nephrologists seemed inclined towards biopsy given the possibility of an alternative diagnosis. And they gave statements like, if we blame all the disease on diabetes, we may never pick up any other etiology. And diabetes does not protect you against amyloid, minimal change disease, membranous GN, or lupus. Just because someone has diabetes, I may biopsy them anyway. While there's no clear consensus on when to biopsy in diabetes, in general, the indication appears to be that there's a reasonable probability that there is non-diabetic kidney disease. One paper I came across outlined major and minor recommendations for biopsy, which seemed consistent with what I've learned during training. And these are suspicion of systemic disease, such as cancer, AKI, hematuria, especially dysmorphic cells, nephrotic syndrome or proteinuria with a diabetes diagnosis less than 5 years ago, and the absence of retinopathy. And for minor recommendations, microalbuminuria without retinopathy, a rapid increase in proteinuria, or an increase in proteinuria with a diabetes diagnosis less than 5 years prior. What's interesting is that the criteria that you use to determine whether or not to biopsy really does impact the distribution of pathology that you see. One study conducted in Italy compared kidney biopsy findings in people with type 2 diabetes that were performed across two groups of centers that had different biopsy policies. Half of centers had a restricted biopsy policy, and this amounted to biopsying when there was hematuria, nephrotic syndrome, urine protein creatinine ratio greater than 2 grams per day without retinopathy, or rapidly progressive kidney failure. And the other center had what they called an unrestricted biopsy policy, where patients were biopsied if they had a urine protein creatinine ratio greater than 0.5 grams per day with or without hematuria or reduced eGFR. And both centers explicitly discouraged biopsies when diabetic kidney disease was considered extremely likely. It seemed to me like the major distinction between these two policies was the degree of albuminuria, but otherwise, I didn't think they were too different. And yet, in the restricted biopsy policy group, about half of the biopsies show non-diabetic kidney disease. That's the yellow and green boxes alone. NDKD stands for non-diabetic kidney disease, DN for diabetic nephropathy. And 1/3 had diabetic nephropathy alone, whereas in the unrestricted biopsy policy group, these proportions are flipped. Half have diabetic nephropathy alone, and 1/3 have non-diabetic kidney disease. Recently, here at UW, we published a study, manuscript led by Sarah Sangavi, that described the clinical and laboratory parameters associated with diabetic nephropathy versus non-diabetic kidney disease in a UW biopsy cohort. And this study retrospectively looked at close to 400 people with diabetes who had had a clinically indicated biopsy, and detailed clinical data was available for a subset. About half of this cohort had a primary diagnosis of diabetic nephropathy, and the other had a primary diagnosis of non-diabetic kidney disease. And the features associated with nephropathy, diabetic nephropathy, were retinopathy. This was actually pretty sensitive and specific, over 80%. And higher proteinuria was also seen with diabetic nephropathy, 7.6 grams over 4 grams. And a description of AKI was seen with non-diabetic kidney disease. Interestingly, hematuria was not predictive of non-diabetic kidney disease in this cohort. And overall, 20% of everyone biopsied had a treatable diagnosis. I found this to be less than what I expected. These are findings from another large study describing distribution of pathology in clinical biopsies performed in people with diabetes. This one has 600 participants. And here, about 1/3 had diabetic nephropathy alone, 1/3 had non-diabetic kidney disease alone, and another third had both. The most common non-diabetic kidney disease lesions seen in diabetic nephropathy were ATN, hypertensive nephrosclerosis, and FSGS, which I wonder if, are maybe related to the diabetes in some way. And there were a few clinical features that differed between the diabetic and nephropathy and non-diabetic kidney disease groups. Abnormal SPEPs and low C3 and C4 were seen more with non-diabetic kidney disease. But interestingly, only a quarter of people with these abnormal tests had pathology related to these findings. Here, proteinuria greater than 3.5 grams was also seen more commonly with diabetic nephropathy compared to non-diabetic kidney disease, similar to the UW study. And the variable that ended up being most predictive of diabetic nephropathy alone was a length of diabetes duration. If you had diabetes for longer than 12 years, the specificity of biopsy showing diabetic nephropathy alone was 73%. And this study did not have retinopathy data available. So back to our original question of why don't we biopsy people with diabetic kidney disease more often, or with diabetes more often? It's not because our ability to make a clinical diagnosis is perfect, right? I just showed that 3 to 5 out of 10 people with diabetes that we biopsy will have diabetic kidney disease, or the positive predictive value of deciding to do a biopsy is like not perfect. The reason we don't biopsy is because right now, a biopsy doesn't add much in the way of diagnosis, prognosis, or treatment for diabetic kidney disease. So wanted to ask, what would make biopsy more useful? Using biopsy to identify subtypes of diabetes may be helpful, for one. Here, showing results from a recent study in the Trident cohort, a large diabetic kidney disease biopsy cohort. Here, investigators quantified a large number of discrete histopathological features, not unsimilar from the morphometric studies I had shown. And they used an algorithm to cluster individuals based on the combination of biopsy features, as opposed to fitting individuals into a predetermined classification system like the Renal Pathology Society's classification system I'd shown earlier. And this algorithm identified 3 different clusters of individuals. Cluster 1 had mild structural changes and not too much eGFR over time. Clusters 2 and 3 were pretty similar clinically. A lot of the points on the radar plot here kind of align, but had one main difference. The second cluster had more glomerular epithelial hypertrophy and hyperplasia. This group also had the most rapid progression to ESKD compared to the other clusters. So if you could use a biopsy to identify a disease subtype that has a distinct prognosis or maybe a response to specific treatment, that would be one way that biopsy is valuable. Also, using biopsy to identify specific dysregulated molecular pathways may be helpful. For example, in our PMIT and DUNE cohort, they had found cortical interstitial fractional volume, a measure of interstitial fibrosis, to be associated with adverse long-term kidney outcomes. So investigators went on to identify genes, transcription patterns that were associated with this specific structural feature, and then to describe the molecular pathways these genes are involved in. Ultimately, they were able to say that dysregulation of metabolic and inflammatory processes is seen with this structural feature, cortical interstitial fractional volume. So if you could use a biopsy to identify abnormalities in specific molecular pathways early in the course of diabetic kidney disease, maybe before these structural features are even apparent, you can diagnose diabetic kidney disease early and provide early targeted therapy. Or maybe you don't need a biopsy at all. Maybe in the future, urine can serve as a liquid biopsy of sorts. How can this potentially work? Well, one of the ways is by sequencing cells found in the urine. It's been shown that podocytes, proximal tubule cells, loop of Henle, and collecting duct cells can all be identified in the urine, and that these exhibit similar expression patterns as their parenchymal counterparts. And you can see here that the urine cells are in blue, and they are, in the same kind of grouping as kidney cells of the same type. And when you sequence these cells, you find that the cells in the urine express the same genes as those in the kidney. So you can potentially use them to identify drug targets or disease molecular subtypes. And here I'm showing that podocytes in red in the urine express VEGF strongly, and loop of Henle cells in the urine express our sodium potassium chloride transporter gene strongly as well. So maybe in the future, we can identify dysregulated molecular pathways and determine potential responses to specific therapies using urine alone. So having reviewed kidney biopsy findings in diabetes, I'd like to close with a clinical case. This is taken from a case report recently published in CJASN. Our patient is a 66-year-old woman with a past medical history of coronary artery disease, type 2 diabetes, hypertension, hyperlipidemia, MGUS, and primary hyperparathyroidism. And she's referred to nephrology for evaluation of proteinuria. She was diagnosed with diabetes 5 years ago. Her A1Cs have been largely less than 7%, only on metformin, and she does not have retinopathy. And she was diagnosed with hypertension 30 years ago. Her blood pressure had been uncontrolled, initially on candesartan, but improved 20 months prior following a 20-pound unintentional weight loss. Here are medications, her physical exam, and the labs that were available in the case report: creatinine of 0.87, corresponding to an eGFR greater than 60, urine protein creatinine ratio of 2.3 grams per gram, 200 milligrams of albumin, and a calcium of 11.1. And I know you'd all, typically want a bit more clinical information, but I don't have more than what I'm showing now. So the question I'll ask that I know I don't think I have the poll feature available, so y'all can think it or put it in the chat, is what is the likelihood that this person has diabetic kidney disease? Are they extremely likely, extremely unlikely, or somewhere in between based on the clinical scenario? And I'm not able to see the chat, so I'm assuming people are just thinking about it. So a diagnostic procedure was performed, a biopsy, which demonstrated 2 out of 20 globally sclerotic glomeruli with overall normal mesangial matrix and cellularity and capillary wall thickness. It's mild IFTA, 10% with mild chronic inflammation, and mild arterial sclerosis and arteriolar sclerosis, as well as tubules with some changes of acute injury. IF was negative for all markers, and EM showed no GBM thickening, but did show some mild ischemic wrinkling and foot process effacement at 10%. So the final biopsy, pathology diagnosis here was mild hypertension related injury, no mention of diabetes related injury. But there is a molecular diagnosis as well. RNA sequencing was additionally performed across different nephron segments, and gene expression from these different nephron segments was compared to, from this individual, was compared to that of controls without kidney disease. And then pathway analysis was applied to differentially express genes to identify molecular pathways that were overrepresented in each nephron segment. And this is shown in this figure on the right. For example, pathways involved in the renin-angiotensin system and insulin resistance were enriched in the glomerulus. And overall, molecular changes were present that were reflective of adaptive responses in the adaptive responses to diabetes in the glomeruli, interstitium, and proximal tubules. And moreover, these changes correspond to pathways that have been linked to structural and functional changes in diabetic kidney disease. So perhaps the actual final diagnosis was mild hypertension-related injury and the beginnings of diabetic kidney disease. And so that is all I have for today. I want to thank all of my mentors at UW and the projects that helped inspire this deep dive into the kidney biopsy and diabetes ProRAS project with Brian, Francis, Andy, David, and KPMP. And at this point, I'm happy to take any questions.
Thanks so much, Christine. I think we have time for 1 or 2 questions.
I have a question. Christine, really excellent talk. It was a wonderful overview. So how would you summarize? When would you actually recommend a kidney biopsy?
Yeah, so I would say that our clinical based on the studies that have relied on existing biopsies, I would say our clinical gestalt is pretty okay. And this appears to be based on what I think is a not completely accurate, timeline for the progression of diabetic kidney disease. For example, we tend to, biopsy when we see rapid increases in proteinuria over time, but this can be seen in diabetes. But at the same time, I think that's fair because that can also be seen with things like membranous GN and other conditions. So I'd say I largely agree with the recommendations that were provided for abrupt changes in EGFR, proteinuria, hematuria. I would additionally say that long-standing diabetes and the presence of diabetic retinopathy would, push me very much towards diabetic kidney disease.
Christine, that was absolutely beautiful, beautiful talk, and it answered so many questions that I carry with me in every clinic session, basically. I've always been very interested in these people, these 35% of people that have significant diabetic kidney disease on biopsy, and yet they don't have any albuminuria at all. And so how do we explain the kind of glomerular destruction and architectural changes without albuminuria? Those people tend to progress much more slowly. And is there a way to change the phenotype from the albuminuric patients back to the non-albuminuric, or how is it even possible that they don't have albuminuria? So,
yeah, that's a great question. And actually, one of the earlier classification systems had divided diabetic kidney disease into 3 categories. One with glomerular changes, one with only interstitial changes, and one without like many changes at all. So I think what you're describing, would fit more the interstitial changes. And I don't, know the answer to that. I don't fully understand like why some people don't develop as severe glomerular lesions. They did show that albuminuria and those lesions can remit with treatment of hyperglycemia and control of diabetes overall. So I would say, doing what we're doing is the appropriate way to go, but I don't have an answer for the reasons for the differences between those groups.
Great. Well, thank you so much, Christine. I'm sure we could keep the Q&A going for quite a while, but we'll move on.